Hello everyone! In the previous lesson, we explored the basis of the complete blood count and got a quick introduction to the automated hematology analyzers. And in this video, we'll focus on the something essential, the red blood cell indices, how to read them, what they mean, and how they help us understand different types of anemia. So now, let's get started. And now, let's begin with the red blood count, or the RBC. It represents the number of the red blood cells in 1 microliter of the whole blood. And in the healthy adults, the normal range is 4.7 to 5.4 million per microliter in males, and 4.3 to 5 million per microliter in females. An increased RBC count may suggest the polycythemia, or it may result from the hemoglobin concentration, for example due to the dehydration. On the other hand, a decrease in the RBC is commonly seen in the anemia, or sometimes it may reflect the hemodilution, such as in the fluid overload of the pregnancy. So, we have to remember, when interpreting the RBC values, always think about both red cell mass and the plasma volume changes. And now, let's move on to the hematocrit, or the HCT value. Hematocrit represents the proportion of blood volume occupied by the red blood cells. When we centrifuge a blood sample, it separates into two main layers. Remember, the plasma on the top and the red cell at the bottom. The hematocrit is calculated as the volume of the red blood cell divided by the total blood volume, which includes both RBC and the plasma. So essentially, it tells us how much of the blood is made up from the red blood cells. And in the healthy adults, the normal hematocrit ranges are from the 42% to the 52% in males, and 37% to 47% in females. A decrease in the HCT can reflect anemia, but it may also result from the hemodilution, such as in the pregnancy, or fluid overload. An increased HCT may be due to the polycythemia, or sometimes due to the hemoglobin concentration, like in the dehydration. Just like the RBC, HCT is affected not only by the number of the red cells, but also by the plasma volume. So again, when you see a high or low hematocrit, always ask, is this a true red cell change, or is it a plasma volume shift? Okay, now, let's take a look at this case together. A 32-year-old woman presents with a mild fatigue. She looks pink, well perfused, and her vital signs are stable. But her CBC shows a low RBC and HCT. The sample was repeated properly, and the result was the same. What is the most likely explanation for this result? Take a moment and think about your answer, A, B, C, or D. Alright, let's break it down together. First, the patient looks completely well. She is pink, her perfusion is good, and her vital signs are stable. That doesn't match a picture of a true anemia. Next, there is no mention of hemolysis in the tip, and the sample were properly labeled and repeated, so C and D are unlikely. Now, let's go back to the option A. The sample were drawn from an arm with an ongoing intravenous infusion of normal saline. Does it make sense? If the blood was drawn from the same arm as an intravenous line, the sample could be diluted with the saline, making the RBC in the XCT appear falsely low. So the best answer for this question is A, a sampling error due to the hemodilution from the intravenous fluids. Now, let's talk about the hemoglobin, or the HB, or sometimes for the HB. Hemoglobin is the red pigment inside the red blood cells, and its main role is to carry the oxygen from the lungs to the tissues. And each hemoglobin molecule is made of two main parts, heme and globin. The heme group contains iron and a porphyrin ring. However, the globin part is made up of two alpha and two beta chains. This structure will be important later when we discuss the condition of the anemia related to the hemoglobin synthesis. The hemoglobin level represents the concentration of the hemoglobin in our whole blood. It is important because it directly reflects the oxygen carrying capacity of the blood. Unlike the hematocrit or the RBC, hemoglobin is directly measured, not calculated. So, it's considered highly reliable. Another key point, it is minimally affected by the plasma volume, so which makes it more stable in case of dehydration or fluid overload. That is why the World Health Organization, WHO, uses hemoglobin as the primary standard to define anemia and the polycythemia. A low hemoglobin indicates the anemia, while a high level suggests the polycythemia. And these are the WHO hemoglobin threshold used to diagnose anemia in different age groups. As you can see, the cutoff levels vary depending on the age and the sex. For example, in men, anemia is defined as the hemoglobin is lower than 13 grams per deciliter. However, in non-pregnant women, its hemoglobin is lower than 12 grams per deciliter would be used to define anemia. There are also criteria for children of different age groups, but in this course, you only need to focus on the adults, men and women. And also, just a reminder, this module will focus on the anemia only. We won't cover polycythemia in detail, so you don't have to study the polycythemia criteria. Only the anemia criteria only. And now, when interpreting the hemoglobin levels, remember that several factors can affect the results, including the pregnancy, age, and acute blood loss. Let's start with the pregnancy. From the early to late pregnancy, both red blood cell mass and the plasma volume increase. However, the increase in the plasma volume is much greater and faster, leading to what we call the physiological hemodilution. As a result, hemoglobin concentration along with the hematocrit and the RBC often shows a relative decrease, even though the red cell production is actually going up. That's why the anemia threshold for the pregnancy is lower than the non-pregnant women. Hemoglobin is lower than 11 grams per deciliter compared to the lower than 12 grams per deciliter in the non-pregnant women. And now let's look at this case. A 28-year-old woman recently married come in with 5 weeks of missed period. Her urine pregnancy test is positive, and her hemoglobin level is 10.5 grams per deciliter. The question is, does she have anemia? Now, take a few seconds to think about your answer, A, B, C, or D. Alright, let's break it down. First, the patient is pregnant, and we will just learn that the WHO defines anemia in pregnancy as the hemoglobin level less than 11 grams per deciliter, regardless of the trimester. So, although she's only 5 weeks, the cutoff is still 11, not 12. That means option B is incorrect. 12 grams per deciliter is the cutoff for the non-pregnant women. Option C is also incorrect because her hemoglobin level is actually lower than the pregnancy threshold. And the option D is tempting, but the diagnosis of anemia in this case is already clear. So the correct answer is A. Yes, because her hemoglobin level is lower than 11 grams per deciliter. And here's the important point. The World Health Organization uses a single cutoff of 11 grams per deciliter for all pregnant women, regardless of trimester. This helps ensure consistency in the clinical diagnosis and global research. Even though we know the hemoglobin level may fluctuate throughout the pregnancy and some kind of not different with the non-pregnant women at the early of the pregnancy. And this table shows the WHO criteria for classifying anemia severity based on the hemoglobin levels. It applies to different population groups and divides anemia into mild, moderate, and severe. When you are on the clinical rotations, you should use this to accurately state the chronic anemia severity. But for this course, it is not part of the core learning objectives, so you don't have to study this table. However, when you are on the clinical rotation, I would like you to use this table to assess the severity of the anemia. Age is another important factor affecting the CBC interpretation. Let's go along the timeline. From newborns to infants, adolescents, and finally to the elderly over 60 years old. For the red cell line, newborns often have the physiological polycythemia, a high red cell count at birth, but soon after birth, this drops rapidly. In infants, iron requirements are high, but the breast milk alone may not provide enough iron, leading to the physiological iron deficiency, which is usually mild and temporary. As children start eating solid food, RBC indices normalize and remain stable through the adolescence and the adulthood. But after the age of the 60, red cell production may decline due to the chronic inflammation, bone marrow aging, or hormonal changes. For white cells, physiological leukocytosis, a high white cell count, is also seen at birth, but this normalizes within hours to days. WBC, or the white blood count, stay relatively stable throughout our life, but can decline in the elderly due to the same factor with the red cell indices, chronic inflammation, bone marrow changes, and anti-hormone level, all of which impair the hematopoiesis in the bone marrow. And the third factor that affects the red cell indices is acute blood loss. Now let's take a look. In the first hours after bleeding, both red cell and plasma are lost proportionally. So the RBC, HGB, and the XCT values may appear normal. But over the next 24 to 48 hours, the body compensates by restoring the plasma volume faster than the red cell mass. So, this leads to the drop in the RBC-related indices, which then reflect the true severity of the anemia. So remember, the HB, XCT, and RBC only accurately show the acute anemia after 24 to 48 hours after acute bleeding. Now, to classify the anemia by the morphology, we use three red cell indices: MCV, MCH, and MCHC. The MCV tells us the size of the red cells. If the MCV is below 80 femtoliter, the red cells are microcytic. But if it is between 80 and 100 femtoliter, the red cells are normocytic. But when the MCV is above 100 femtoliter, they reflect that our red cells are macrocytic. And for the MCH and the MCXC, they reflect the hemoglobin content as well as the color of the red cells. When they appear with the low values, they reflect that the red cells are hypochromic. But when they are normal values, they reflect that our red cells normochromic. So at this point, you might wonder, why isn't there a category called hyperchromic? That is because the red blood cells can only produce and carry a limited amount of hemoglobin, usually no more than 32 picogram for the MCH and 360 gram per liter for the MCXC. Once the threshold is reached, hemoglobin synthesis is stopped and the cell cannot become more chromic. In older literature, you may still see the term hyperchromic, but that was before these biological limits were well established by the researchers. Anemia can be classified by the red cell morphology using two key indices, MCV and MCH. Based on these values, we divide anemia into three major types: microcytic hypochromic anemia, normocytic normochromic anemia, and the macrocytic anemia. This classification provides the first step toward understanding the underlying cause, which we will explore next. Before we move on, let's pause for a quick question. In complete blood count, what does the MCV actually stand for? With the A, B, C, and D choices on the screen, take a moment and think about the answer. And the correct answer is D, mean corpuscular volume. It refers to the average volume of a population of red blood cells. And now, we will turn to the part of the anemia causes. The first one. This is the classic image of the microcytic hypochromic anemia seen on the peripheral blood smear. Most of the cells are smaller than normal. That is the microcytic part. And notice the pale central area. Normally, the central pallor should be less than 1/3 of the cells. When it becomes wider, it indicates the lower hemoglobin content, and that is what we call hypochromia. When we talk about microcytic hypochromic anemia, we need to go back to the hemoglobin synthesis. The volume of the red blood cell is closely related to the amount of hemoglobin it contains. Hemoglobin is made of two key components: heme, which form from the iron and the porphyrin, and the globin, which made up from the protein changes, mainly alpha and beta. Disorder affecting any of these components, iron, porphyrin, or globin chains, can reduce the hemoglobin synthesis. And when the hemoglobin is reduced, red blood cells tend to be smaller and paler, leading to the microcytic and hypochromic anemia. Therefore, disorder can occur at 3 levels. First one, porphyrin disorders. These include the rare conditions like lead poisoning and sideroblastic anemia. And the second, iron-related disorders. This is one of the most common groups. You must remember the iron deficiency anemia as well as the anemia of chronic inflammation. And the third, globin disorders. These affecting to the protein part of the hemoglobin. The key disease here is thalassemia. All of these conditions reduce the hemoglobin production, leading to the smaller paler red cells, the hallmark of the microcytic hypochromic anemia. So, these 3 conditions in red, iron deficiency, chronic inflammation, and thalassemia are the must-know causes to remember when we talk about microcytic hypochromic anemia. Not all the anemia involve changes in cell shape or size. In fact, some forms of anemia show no morphological abnormalities at all. Red cells look completely normal under the microscope. That leads us to the next group, the normocytic and normochromic anemia. Normocytic and normochromic anemia can be caused by 2 major mechanisms. First, loss or destruction of the red blood cells. This includes the hemorrhage like acute bleeding and the hemolysis, the premature destruction of our red blood cells. The second mechanism, reduced red cell production, which can be divided into the extramedullary causes like the chronic kidney disease and intramedullary causes such as aplastic anemia or the bone marrow malignancy. So, even when red cells appear normal in size and color, the problem can lie in the production, the destruction, and the loss of the blood cells. Finally, we come to the third morphological group, macrocytic anemia. As you can see in the plasma, many red cells are noticeably enlarged, yet still round and evenly stained. In the next slide, we will explore what causes red blood cells to become abnormally large. And the macrocytic anemia can result from 3 major mechanisms, each linked to the different underlying condition. The first, abnormal nuclear division. This is the most important group, including the vitamin B12 or the folate deficiency anemia, as well as the drugs that inhibit the DNA synthesis, such as in the chemotherapy. So, to understand why defective nuclear division causes macrocytic anemia, we need to look back at how our red blood cells develop in the bone marrow. During the erythropoiesis, immature red cells, erythroblast, go through several rounds of the cell division while also synthesizing hemoglobin. And this process requires the balanced growth of the nucleus and the cytoplasm. When there is a vitamin B12 or folate deficiency, the DNA synthesis is impaired, especially in the nucleus. So, the nuclear maturation slows down while the cytoplasm continues to mature normally. This mismatch leads to a cell with a larger size, immature nucleus, but mature cytoplasm. These abnormal precursors are called the megaloblast, and they give rise to the larger than normal red cells in the peripheral blood. That is why we call it is the megaloblastic anemia, and why it shows up as a macrocytic on the CBC result. The second condition, increased increase the reticulocyte count. After acute bleeding or hemolysis, the bone marrow releases more immature red cells, the reticulocytes, which are larger in size. Now, you might wondering whether an increase in the reticulocytes causes the MCV to go up. I will come back to that in just a moment. But before that, here's something important to remember. MCV reflect the average volume of all population red cells in the blood, not only the single red cells. So, even if only a subset of red cells become larger in the peripheral blood, like newly released reticulocytes appear, they can still raise the overall average and increase the MCV. And the last one, abnormal red cell membrane, seen in the chronic liver disease, where the red cell membrane becomes altered, resulting in the larger cells. So, in conclusion, when you see the macrocytic anemia, always think about three core mechanisms and three main causes to guide your differential diagnosis. And three main causes that I want you to remember are the first one is the B12 and folate deficiency anemia. The second, acute hemolysis or hemorrhage. And the last one is the chronic liver disease. So I want you to remember three causes like that. Let's pause for the quick check. Think about what we discussed so far. What type of anemia is typically seen in the chronic kidney disease? Look at three options on the screen and think about the answer. So the correct answer is B, normocytic normochronic anemia. Because in the chronic kidney disease, the red cell production decreases, but the cell size and the color remain normal. Alright, and here's your next questions. What type of anemia is typically seen in the thalassemia? Thalassemia is a globin chain disorder. That means hemoglobin can't be synthesized effectively. And when hemoglobin is low, the red cell it becomes smaller and contain less color. That's why thalassemia typically presents as the microcytic and hypochromic anemia. So, our correct answer is A. Here's another quick check. What type of anemia would be expected in vitamin B12 deficiency? Take a few seconds to think about the answer. Alright, let's reason through this. Vitamin B12 is essential for the DNA synthesis during the red cell development. Without it, nuclear division is impaired while cytoplasmic growth continues. That leads to large but immature red cells appear in our peripheral blood. So this is classic case of the macrocytic anemia. So our correct answer is C. Now let's talk about the RDW, which stands for the red cell distribution width. And it tells us how varied the size of red blood cells are. If all red cells are in the same size, the RDW is low and the bell curve of the RDW is narrow. However, if there is a mix of small and large red cells, RDW value will be higher and the curve will become wider. So, what does it mean when the RDW value is? Normal RDW is between the 11.5 to the 14.5%. It reflects the red cells are mostly uniform in size, like in the healthy individuals. However, increased RDW is when the RDW value is higher than 14.5%, and In this situation, it reflects that there is an anisocytosis. Anisocytosis, you remember that? A medical term meaning the variation in the red cell size, often seen in the iron deficiency anemia, as well as the mixed nutritional anemia, or after blood transfusion. Now, here's something important. You will never see the RDW value is zero, because even in the perfect health, there is always some natural variation in the red cell size. And in conclusion, RDW doesn't tell us if the red cells are big or small. That's what the MCV value does. The RDW value tells us how diverse their size are. So you remember that? And let's summarize with this comparison. On the left side of your screen, you will see the normal RDW. Most red cells are uniform in size, and the bell curve is narrow, meaning the low variation of the red cell size. However, on the right side, we will see the increase the RDW. Most of the red cells vary widely. Some are extremely large, but some are very small. And the bell curve becomes wider, showing more size variation. So remember, RDW increases when there is a mix of different size red cells. So that is the key clue in many types of anemia. Now let's take a look at these two blood smears of mild microcytic anemia. On the left side, you will notice a wide range of the red cell size. Some are very small, others are closer to normal. That tells us that RDW is increased because the cell size is highly variable. This pattern is typical of the iron deficiency anemia, where the body is struggling to produce normal red cells, so you get a mix of small and oddly shaped cells. On the right side, all red cells are uniform, but they are similar in size, although there are some smaller red cells. So our RDW is quite normal. This is more consistent with the thalassemia trait or minor. So remember, in iron deficiency anemia, our RDW is increased. And in the thalassemia trait or minor, our RDW is normal. So, RDW value is one of the methods that you use to differentiate mild microcytic anemia. Now, the final information that I want to introduce to you is a useful clinical method called the Mensa index. The Mensa index can be calculated with the MCV value divided by the RBC value. And we use this index to differentiate between the iron deficiency anemia and thalassemia trait or minor, both of which can cause the microcytic anemia with mild severity. Now let's apply it to these two blood smears. On the left, we see small red cells, so clearly MCV is low. Moving to the right smear, our red cells are also small. However, some other look like normal, but so the MCV is quite low. And now let's look at the number of the red cells. In the left smear, the cells are not only small but also reduced in number, and so the RBC is low. But in the right smear, even though the cells are small, there are many more. So our RBC in this picture is normal or increased. So now let's calculate. In the left smear, with the degree of both MCV and RBC, so our Mensa index would be increased. So when it's increased more than 13, it will reflect that our blood smear is appropriate with the iron deficiency anemia. And in the right smear, the MCV is decreased while the RBC is normal or increased. So our mental index decreases is lower than 13, and it will suggest the thalassemia trait or minor. So one more method that we use to differentiate the mild microcytic anemia is Menzel index. Remember that. Okay, now let's wrap up with a few key takeaways from these lessons. In summary, remember to check the HCP to confirm the presence of the anemia. Then, the MCV as well as the MCX help us to categorize the type of anemia based on the size and the hemoglobin content of the red blood cells. And this overall approach gives us a broad understanding of the anemia nature and helps to guide further investigation. In the next video, we will dive deeper into isolated abnormalities in the red cell indices, what they mean and how to interpret them step by step. So, see you there. Thank you for watching.